Ahí fue la más.
அவங்க யாரா வந்தாதான் பேசுறது கேட்கணும்.
I thought
please maintain silence. I want all of you. Just switch off the light. In the light. Switch off the light.
good afternoon, ma'am.
Good afternoon. Sorry, Ji. 1 second.
Ma'am, can you just share your screen and just see if it's shared?
Yeah,
Can it-
that's what I'm doing it. Are you able to see my slides?
Yes, ma'am. Yes, ma'am. Yes.
Okay, 1 minute. I want to run a video also. Is it also running? I want.
Can you all listen? All of you just keep quiet. Pin drop silent. Okay. I don't want any one of you talking about. Okay.
1 second.
Ma'am, can you just go on to a small introduction, ma'am, before
One
we...
minute. I want to run a video also. I'll try to run that also if it is possible. Huh?
Video, ma'am.
Yeah. I want to see whether that is also happening. That's all.
Okay.
Is it possible? Is it viewable?
Yes, ma'am. You can see that the voice is not audible, ma'am.
Not able to see? Were you able to see the videos?
I was able to see the video, ma'am.
Okay.
But I couldn't hear anything. I could see, but not hear.
Okay. The audio is also quite loud.
Or shall we start, ma'am? We can just try
Yeah.
after.
Yeah.
Let's start, ma'am.
Yeah.
I just wanted to share my slide, ma'am.
Yeah, sure.
A very good afternoon to one and all who are attending this CME program online as well as offline. So I cordially welcome all the speakers, the chairperson. I express my sincere gratitude to Madras Medical Management um, for giving us full support in conducting this nutrition education program. This program is conducted in association with IAPN India, Chennai chapter. So IAPN India is an Indian Association of Enteral and Parental Nutrition. It's an association formed with doctors and other healthcare providers to improve the nutrition care in the hospitals. So we have conducting a lot of every month nutrition education program to update us on the latest guidelines and to practice and to make it more practical in our hospital setup. So for more information about IAPN India, you can log into the website and all the details are there. We invite people to become a member of IAPN India and all this information are available online. So all of you know, like February 4th is observed as World Cancer Day. And we find that the occurrence of cancer is increasing day and day. It is increasing more. It is mostly because of there are various causes for this cancer occurrence. One being the very important is diet and lifestyle. Not only that, after having a cancer and patients undergoing a lot of treatment, chemotherapy, radiation, nutrition plays a very important role in the better outcome. So it has to go hand in hand for better outcome. So the nutrition plays a very important role in the prevention of cancer. Not only that, during the treatment also, nutrition has to go hand in hand. So we have a well-renowned speaker. We have chairperson with us to take this program forward. So we have Dr. Senthil Kumar, Senior Consultant Surgical and Lab Cancer Surgeon from Madras Medical Mission, and Ms. Rajeshwari. She's a Senior Clinical Dietitian from Apollo Cancer Hospital, and she is also a Treasurer of Chennai Chapter, IAPN India. So to tell some few words about Dr. Senthil Kumar, he's actually an MS in Madras Medical College, and he did his MBBS in Kilpauk Medical College. He has a publication, around 8 publications, and he's assistant. He was an assistant professor and surgical oncology in Cancer Institute for 1 year and 9 months. And he was also working in Savita Medical College since April 2015. And so presently he is a senior consultant surgical oncologist at Madras Medical Mission. So I welcome you, sir, to our program. I would also like to welcome Rajeshwari ma'am to this nutrition education program. She is a senior clinical dietitian at Apollo Cancer Hospital. She is a member of Indian Dietetic Association as well as IAPN India. And she has attended a lot of LLL program, and she is a well-renowned speaker in nutrition in a lot of programs. So welcome you, ma'am, for our program. Forward to hear from you. So I would like to welcome Dr. Senthil Kumar to say a few words about the nutrition, role of nutrition in cancer. welcome you, sir.
A very good afternoon, everybody. So we all keep commonly saying this, right? What we sow is what we grow. Similarly, what we get is because of what we eat. So if your nutrition is not going to be correct, either form of malnutrition, either the deficiency or its excess, both are going to have problems. And more so in a lifestyle disease, where you can have more problems is in something like oncology. No consultation in an oncology clinic is complete without discussion on diet and nutrition. Okay, very important part. In fact, our treatment depends on what is the nutritional status of the patient. If the patient is nutritionally depleted, we may not be able to give the optimum care. So it is imperative that clinicians and dietitians work together, make sure that the patient has a very good nutrition so that he can get the optimum care and hence look at cure. And in cases, even in patients where we are not able to cure, even in that situation, you have to make sure that nutritional part is taken care of so that they have a adequate palliative and they have a good quality of life and even a terminal care even. And to speak on this topic, we have an excellent speaker today, Rajeshwari, a senior dietitian from Apollo Group of Hospitals. He's also the treasurer of the IPN Chennai chapter. I've had the opportunity to listen to her a few times. Excellent speaker. Without much ado, I hand over the podium to Dr. Rajeshwari. Ma'am, over to you, ma'am. Thank you.
Thank you, sir. Thank you so much for the short intro. And without much delay, I would like to go ahead with the presentation. Hope the screen is viewable.
Yes, ma'am.
Yeah. Fine. Fine. So the topic which I'm going to have it for the today's session is on new perspective and nutrition support and therapy in cancer treatment. So as we all know, the science is one area where each and every day we have new inventions. It's been happening, new technologies, new treatments which has been offered, been for the treatment. Everything is been happening among the in the field of nutrition, and as well as the treatment which we are having offered for the cancer treatment. So February 4th, that is being considered as a World Cancer Day. And this year, the theme is Together We Can Beat the Cancer. So that is what the theme hit us. So something it was related to our today's topic also, because whatever we have the conventional treatment we are offering currently for a cancer, we are having some of the upcoming treatment that has been, it is a little more, very pioneering. We are having, very reliable method. Also, it's upcoming process we happen to see to it. So probably there is a transition of the treatment is also been happening. So probably I wanted to highlight on few, new innovations that has been happening in the field of treatment, in the cancer treatment, and what are the therapies which we are having on part of the nutrition also. I just want to share it up. So as we all know, the cancer is a global health problem that is responsible for almost 1 in 6 deaths that's been happening worldwide. And in 2020, it was been estimated almost 19.3 million new cancer cases, and also about 10 million cancer deaths globally that has been identified. And above all this, diet is also plays a major role in cancer treatment, whether it's been a cancer survivor or the person who's been under treatment. It is the nutrition plays a major role. So designing a diet that may improve patient responses to the cancer therapy is known as precision nutrition. The nutrition therapy which we are going to have it in the upcoming years, this is what we are going to face it. We are going to face it up. So I just wanted to highlight on what is precision nutrition. Precision nutrition is nothing but is an approach of developing a comprehensive and dynamic nutritional recommendation based on the individual variables. Usually what we are doing is, once a patient has been identified with cancer, probably we'll check the patient's height, weight, their the history, the dietary history. We'll be monitoring it, whether the patient had a normal food intake or they had any GI discomforts. So these were the common terminologies or the common variables we were looking forward. But in this particular precision nutrition, they are going beyond that. They'll be focusing on genetics, microbiome, metabolic profile. Also they'll be looking onto it, and health status, physical activity, dietary pattern, and food environment as well as the socio-economic status is also being considered while planning a diet for a patient who is undergoing for a cancer treatment. So this is what given in a very nutshell they had given to us. As we all know what the precision nutrition in cancer therapy, we can see cancer diagnosis, how it has been identified, the location, the stages has been identified, what the treatment plan we all knew, the surgery, radiotherapy, chemotherapy, and targeted therapies we are having, and metabolomics and nutrigenomics, microbiome screening also is being done, and comorbidities. This gives a precision nutrition where we can bring the patient's outcome. The quality of life is also we can able to avoid a quick recovery as well as a good quality of life. We can see in those individuals when we go in depth while having the nutritional interventions also. So what are the potential benefit of having this precision nutrition? We can have improved quality of life. The patient health is also has been improved simultaneously, and there will be a good therapeutic response as we are having a multiple combination of therapies that is being offered for a cancer treatment. It is not a single treatment that is being given for a cancer patient. It is a multiple treatments which we have been offered. We have chemotherapy or radiation or combination of therapies we are going, targeted therapies we are having, immune therapies we are having to it, and we have surgical interventions we are having to it. So all these therapies, this will improve when we are focusing on the base or on the root of the tumor and finding out how well we can plan a diet for patients. So what are the other things which happens to the cancer thing is like cancer progression can be reduced, therapeutic toxicity can be reduced, and therapy resistance also can be reduced in those individuals when they have when we have a planned nutrition diet plan we are offering for the patient. So what are the current approaches they're recommending is we have the calorie restriction and fasting, and we have a Mediterranean diet. These are the upcoming diets that is being recommended in the precision nutrition. And we have dietary restrictions we are having, and even the dietary supplements are being offered for this. So there are certain pros and cons with this current approaches. So that is also we are going to see what are the pros and what are the cons, and how well we can take it in our day-to-day practices also. We can just going to highlight on that. So what are the key milestones? We have the characterization of the cancer diet restriction interactions, and then trials we are having on dietary interventions, standardized protocols we can have it, and fight through output of metabolism and microbiome, and screening is being done. So the first thing is the calorie restriction, what we commonly call as intermittent fasting or ketogenic diet. So calorie restriction is the current phenomenon, what has been current phase that has been happening, that has been recommended. Most of the dietitians, they're doing it up. So almost it consists of 20 to 40% of reduction in the daily average caloric intake without occurring the malnutrition. So that is the main focus, is without making the patient become malnourished. They want to focus on the calorie restriction, sufficient calorie with sufficient amount of other nutrients like vitamins and minerals has been supplemented to the patients. And what they mean is the circulating glucose concentration is the first decline under the calorie restriction conditions. And it also results in the utilization of stored glycogen. What happens when you restrict on the calories? Probably these glycogen just being stored, being utilized for the energy purposes. So that is also we can able to see to it. And once the glycogen stocks are being totally depleted, the organism uses the glycerol and fatty acid, and it has been metabolized for the adipose tissues, and thus forms the ketone bodies and maintain the fuel for the body. So the next part is actually reducing calorie as well as the periodic fasting. What happens is all the diet restrictions what currently being recommended, they say like 1500 calories or 1200 calories. So the main focus is we want to cut down on carbs. So that is the main focus. So when they cut down that, they feel that it will prevent or it will even treat the cancers. So normally what happens is the diet regimen, or normally the calorie restriction regimen, the carbohydrate, which is the main source of the regular diet, is being reduced or replaced with partially or nearly completely by fat or other sources like protein, or mainly by fat, and so to some extent the protein is also being replaced by the place of carbohydrates. And reducing sugar, it also seems to be a good strategy to fight against cancer. But unfortunately, even certain, we should understand that it is not that only sugar feeds the cancer cells, even it is through other forms of nutrient also it has been, the cells has been metabolized and it has been started, occurring in further areas. So providing ketones as an alternative energy source may limit the cancer growth because cancer cells do not efficiently harness ketones for the anabolism. So this is what I wanted to share it up. How the impact of the calorie restriction, the tumors. So when you go for a calorie restriction, automatically these insulin levels, IGF-1, leptin, and cytokines, and then we have the BGF levels. All these will have these growth factors will have an impact on the will reduce the cancer risk and progression. So that is what it will reduce the growth factor signaling, reduce the vascular perturbance, and reduce the inflammation. So ultimately, it will reduce the risk of cancer risk, and the progression is also being reduced in an individual who is following a calorie restricted diet. So in case of normal cells and in case of the cancer cells, the differential stress resistance we can able to see. It will help to increase the maintenance and repair the pathway, and increases the resistance to the anti-cancer therapy, and also the therapy-related reduce the therapy-related side effects because of chemotherapy or radiotherapy. The chemotherapy toxicity will be reduced in those individuals who have undergone calorie-restricted diet. And even in a patient who's having, when you see all the cancer invaded cells, we can able to see the fasting adaptation. We can it's been reduced, and increased sensitization to anti-cancer therapy and increased therapy efficacy also we can able to see it. So main thing is what the positive calorie restriction effect of the positive effect of calorie restrictions is we can because of this intermittent fasting or calorie restrictions or ketogenic diet, we can reduce the inflammation, reduce the organ toxicity because which has been occurred during radiotherapy or chemotherapy, and which will reduce the healthcare utilization and increase the ROAS levels, and even increase the anti-cancer efficiencies and increase the quality of life. So normally they say the pros we having when we have a calorie restriction diet. So normally, what are the cons? Even when you go on for a continuous phase of calorie restriction during your cancer treatment regimen or a treatment plan, probably what are the other complications we can have during the calorie restriction diet is we end up with nutrition deficiencies because we'll be focusing on one particular nutrient, we're cutting down one particular nutrient. So there is a chances for having a nutrient deficiencies. And it also slows the metabolism process. And even we can able to see the muscle loss, and even some of them will have eating disorders. Because when you replace one major nutrient and replacing with the other macronutrient, probably there is a chances for having eating disorders. They'll get adapted to one particular pattern of food items and they'll be comfortable with it. And when you try in later life, probably they will not be having some eating disorders might come across. So that is the reason they might have some eating disorders also. So we have some certain pros and cons when we have the calorie restrictions or even the ketogenic diet or intermittent fasting for the cancer patients. So that is the reason why we're not recommending this calorie restrictions. But there are studies, it's still going on, the researchers is going on, still going on, but we're not having a strong evidence to prove that these calorie restrictions will help to prevent the cancers. But for treatment purposes, it is under research purposes. It's yet to we have to come across certain more studies also. So the second thing is following a Mediterranean diet, cutting down all non-vegetarian sources, mainly focusing on fish or something like that, and having lots of veggies. So mainly the plant-based food items and healthy fats we'll be focusing on, which is having lots of vegetables, fruits, beans, lentils, and nuts, and even lots of whole grains and cereals and pulses they'll be focusing on to it. And the fat is the high amount of extra virgin olive oil is being recommended. So we can see what are the plant-based food items. We can have a small amount of lean meat or chicken, or they are recommending it. It depends upon the climatic conditions and the areas the Mediterranean diet is being planned. So that is what, and they totally avoid, in certain areas, they avoid totally on red meats, sweets, and other desserts, egg, butter, or even the wine has been totally been avoided. But in certain other areas, they recommend wine to some extent. A single serving of wine is also being recommended in certain areas, in certain part of the world, they're recommending on Mediterranean diet. But if a patient is not adapted to having a wine, it is not necessary to recommend them. A moderate amount of cheese and yogurt is being recommended. Little or no meat. You can choose poultry instead of red meat, and even fish can have it, or egg whites, they can go ahead with it. Little or no sweets, or even the sugary drinks or butter. So this has also been cutting down in the Mediterranean diet. So the main concept of having this Mediterranean diet is, which will help to lower your cholesterol level, will help to lower your heart disease, and even to prevent and treat diabetes also. And even this will help you control the cancer invading cells, because when we are cutting down of carbs, probably the main concept is carbs is the only source of nutrition for tumor cells. So that based on that, this approaches is being planned it up. So it is not only carbohydrate, through other sources also, with the tumor cells will get the nutrition for its survival. It will be having to it. Even if you cut down on carbohydrate, it will survive with protein or fat or some other sources also. It will be having its growth, it will be happening into it. So these are the things which we can see to it. When we have a plant-based food items, high in fiber intake, high in monounsaturated polyunsaturated fatty acids, high in phytochemicals, it will reduce the oxidative stress, reduce the inflammations that has been happened during your cancer therapy, and also it will increase the insulin sensitivity and reduce the metabolic syndromes and cardiovascular disease and reduce the risk of cancers. So those who are having, there is a genetical history of having a cancer, probably they'll be having a doubt whether the individual might get it. If a family of parents, like say a grandparent is having a cancer, and all of a sudden the third generation is getting a cancer, so somehow the genetic is being linked to it. So probably what they think is, because of the gene, it has been transmitted, and then what they do is, okay, finally I might get it. So that fear they might be having to it. So even that is one area that is one thing which they need to focus on. They start having what are the diets which they need to avoid during a cancer in order to avoid getting cancer. So in that cases, they can have the Mediterranean diets they can have to it. And even it will increase the microbial diversity, decrease the microbial dysbiosis, and also it will include the bacteroids, lactobacillus in the breast tissues also, which will increase the microbe derivatives and total saturated fatty acids and short chain fatty acids, and increase the secondary bile, and reduce the gut leak and inflammation, and reduce the risk of cancer. So that is what they recommend when you follow the Mediterranean diet. So how to start a Mediterranean diet? They have given a set of series how to go about it. Eat in abundance. Abundance in which there is no limitations on having these particular food items. You can have lots of fruits, vegetables, whole grain, legumes, nuts and seeds. They can have it, olive oil, herbs, and even water is also been taken into it. And what are the sources which we have to take in moderation? Will be like, they can have fish once or twice a week, and poultry, egg, yogurt, cheese, wine, salt, red wine, and with the meals they can have to it. Eat sparingly. Meat and meat products they can have, meat and meat products, sweets and butter. So this is occasionally they are recommending on a Mediterranean diet. So what are the impact of this Mediterranean diet as far as the cancer thing? It reduces the oxidative stress, inflammation, and even it will prevent the metastasis. So if it is a grade 1 or grade 2, probably further metastasis can be prevented if in case we follow a Mediterranean diet. So that is what they claim to it. And even apoptosis, angiogenesis, cell cycle also we can have an impact of having the Mediterranean diet. So Mediterranean diet normally it reduce the oxidative stress, improve the microbiota, reduce the ROS levels, and reduce inflammations. The favorable changes in the immunology also takes place, which will help against the protection against the cancer cells. So what are the things which we can see between the following a Mediterranean diet and a westernized diet is, which is healthy diet, rich in plants-based food items, and low in processed meat, and no overconsumption of calories, no consumption of sugar, salt, and alcohol, potentially elevated intake of CRF levels, that is calorie restricted mimics levels, and systemic high health benefits we have into it. So that will help to keep up your health in a normal level. But in case of vegetarian westernized diet, we can see increased cardiovascular diseases when they'll be having to it. When you're continually having a westernized diet, probably there is the increased chances of becoming obesity, chronic inflammations, chronic respiratory diseases also they'll be having to it, and increased cancer incidence, and increased risk of neurological and degenerative diseases also. So these are the problems can cause because of Mediterranean diet also. We have Mediterranean diet may lead to weight gain from eating more than the recommended amount of fat, because The olive oil is being the only sources we are having. Other than that, we have butter, cheese is being recommended for them. And to some extent, they are recommending on fish, we are using it up, chicken, poultry, we are using it up, and eggs, we are using it. And even high amount of fat in the form of those fats also might increase the weight. And apart from that, low level of iron from not eating enough meat. So as we all know, iron, a good meat is a good source of iron content. So the red meat is good in iron content. Apart from that, we have certain cereals, nuts also we are having, nuts and nuts also we are having to it. And even certain calcium losses also been noted having a few dairy products, because the dairy product, which you see, the limitation has been recommended. Certain amount of dairy products is being recommended. So there is a chances for the calcium depletion, because already a patient who is undergoing a chemotherapy, there is a chances for the bone density will be, they'll be losing bone density. So, so that is also being noted down. Apart from that, following this Mediterranean on top of it, when we follow a Mediterranean diet, probably that will also have an impact on the calcium, the bone density will be reduced in those individuals following the Mediterranean diet. So when we come to a dietary restrictions in cancer treatment, so fasting, carbohydrate, or carbohydrate restriction diet, or ketogenic diet, or following a particular diet, let's say fasting, or intermittent fasting, or carbohydrate restrictions, or a protein restrictions, that is which will help, which is aimed to exploit the difference between the energy metabolism between the healthy and the tumor cells. So what happens when we have a dietary restrictions following a particular type of diet? This chronic energy restrictions and fasting will lead to a reduced blood glucose levels and even the IGF-1 and increase the ketone levels. Even increased ketone level for a longer period is not being recommended. So that is also one major gray area we have to look forward. So the chronic energy restrictions may not be suitable for patients undergoing treatment with chemotherapy or radiotherapy due to the risk of cachexia and sarcopenia. So when we continually following a particular restrictions on calories or carbohydrates or protein or a fat, probably that is also will end up having an increased risk of having this cachexia or sarcopenia. And ketogenic diet or high in fat with restricted carbohydrate intake, which will stimulate the physiological responses of energy restriction, such as reduction in the blood glucose level and IGF levels, which is coupled with the ketones. So protein restrictions with the energy unrestricted plant-based diet with reduced protein also will have an impact on the IGF level concentration. Then those who want a long-term calorie restriction with adequate protein. So we have the vegan, one particular restricted diet which we commonly come across. Recently, I am coming across is the vegan diet. People are coming, the clients were coming up saying that we started having a vegan diet. They're cutting totally on milk products. They are having one particular diet because that is good for the cancer treatment. They started doing it on their own way, following it up. So vegan diet is nothing but entirely cutting out all food items, that is the animal product from the animal sources, they cutting it down. Like no meat, no fish, no egg, or dairy products also totally they'll be cutting it down. And they'll be having only the plant-based, similar like vegetarian diets, they'll be following to it. So vegan diet use plain plant-based food items to replace the protein food items, and some B complex vitamins and calcium is also will be a part of the diet they'll be having to it. But apart from that, how they replace those calcium and B vitamin in the sense like they'll be having soy products they'll be having to it, and even they may be having apart from that, they have some other sources, vegetarian sources, fully based on soy products, and then they'll be having only on cereals, pulses, they'll be focusing on to it. So the vegan diet is totally a vegetarian diet made obviously solely for cancer fighting properties, but some of their processed vegan food items will be high in sodium content. So that is also we have to look into it, because for the preservative purpose, they'll be adding either salt or sugar for the preservative purposes. So that is also they have to look into it. So cutting down totally animal products and having only vegetarian sources as a thing, and very few may be having only egg as a source, as a protein source they'll be having to it, because some protein they need to take it. So they'll be having egg, and they'll be cutting down on all milk and milk products, including curd, yogurt, everything, milk, coffee, tea, milk, everything they'll be cutting down, and they'll be only having only on vegetarian sources. They'll be replacing with either almond milk or soy milk. They'll be having in the place of coffee or tea or something. They'll be having to it. So alkaline diet. This is also one particular thing which we currently there. People started having to it, following an alkaline diet. So what is the concept between the alkaline food item is nothing but alkaline, which is rich in high in pH level, which will fight against the cancer cells. or prevent the formation of cancer cells. So the idea is nothing but the cancer cells will thrive in acidic environment, which has low pH level, and consuming low alkaline food items. Even they have alkaline water also they started having to it, which can raise the pH levels of the blood to make it less acidic and creating a hostile environment for the cancer cells. So normally one thing we have to understand is your body pH level is being regulated by your blood. It is not by any other sources. By any other food sources, we can't be able to control it. So that is what. So body pH is highly regulated by your body, and we cannot change your body's pH level by eating a high in alkaline or drinking an alkaline water. So that is also we have to understand the part of it. Because if currently, recently, which we have come across is started having vegan diet, alkaline water, and even black water they started having to it. For a cancer treatment, they are having so many things. Currently, it's the upcoming, nutrition things they are using for fighting against the cancers. And even certain dietary supplements is also used for cancer treatment. So dietary supplements, it will be totally misunderstood because very few people, they think like particular having vitamin C food items or vitamin C supplements will help against the fighting against the cancer cells. So mainly the nutrition supplement do not prevent or cure disease. That we have to understand to it. Some vitamins and minerals may interfere, and even however the cancer drugs which is being used for the treatment, even that will interfere, the drug allergic reaction also, even the food and drug interaction also will happen. So that is also we should understand while before starting any supplement for a cancer treatment or something like that. So generally, when you see a patient comes for a cancer treatment, they won't immediately they won't start any supplement. They'll be cutting down all supplements like calcium or iron supplement, they'll be stopping to it because whenever they have anemia, because it is because of chemotherapy drug, they'll be having anemia. So there is a note fact. So we can't have a supplement during that time because what they say is whatever supplement that is being given during your treatment, that is being implied by the cancer cells, not by your body. So that is the reason why they're not recommending any supplement during your cancer treatment. So similar one thing is like beta carotene increase the risk of lung and stomach cancer. Vitamin E is also been increases the prostate cancer and colorectal adenoma. And even selenium also reduces the gastric and lung cancer in a population with low selenium levels, but increases rates in those with higher levels. So the people start having particular supplement like beta carotene, vitamin E, and combination of vitamin E and beta carotene also they'll be having to it, which will help you reduce. But one particular thing is which they come across is it is one of the study they have taken, they have done it with head and neck surgery, like vitamin E and beta carotene reduce the toxicity from radiotherapy among a patient with head and neck cancer patient. And it is also, it has found to increase recurrence, especially among the smokers. So a patient who has been a known history of smokers, their incidence of recurrence is also being noted when they have even the supplementation of vitamin E and beta carotene being used. And even antioxidant. Antioxidant also have a mixed effect on chemotherapy, toxicity, but there are no data of the outcome. So people say like antioxidant is good for cell inflammation and all. So, but there is no such evidences that there is no any studies we have come across because certain during the infusion process, generally we won't recommend any antioxidant because generally antioxidants it's meant to prevent the cell inflammation, cell damages. So during chemotherapy, that will be acting vice versa. So that's the reason why we're not recommending antioxidant. And even DHA and EPA supplements also have a mixed effect on cachexia, and it has been currently being potentially tested on the maximize the response to the chemotherapy. So we have a good study also on DHA and EPA on during a chemotherapy also, and we have L-glutamine, which is taken orally, also shown and one to reduce the peripheral neuropathy associated with the oxaliplatin, that is a chemotherapy drug, which is used to treat the colorectal cancer. So that is also, if we have to keenly notice in what ways we can intervene this L-glutamine during colorectal cancer treatment whenever they undergo chemotherapy. And vitamin D, because almost 95% of the people with cancer will have vitamin D deficiencies. So vitamin D appears to have an anti-inflammatory and immune regulating effect in cancer patient. So vitamin D supplementation, they can have a natural sources exposure to sunlight, they can have to it. And prebiotic, the gut bacteria play a major role in fatigue and cognitive issues caused by the chemotherapy. And sometimes it is also known as chemobrain, or we have chemopop, what we call as chemopop. Chemobrain is nothing but there'll be long run a person is receiving chemotherapy drug. These drug will have an these drug will have an impact on the neuro causes and neurodegenerative diseases in those individuals in a long term effect. So they'll be forgetting things. They'll like sort of they'll forget the things much faster. And even they have the they have a complications like listening for hearing capacity will be lost, or even the vision disturbances they might be having to it, or even they have some walking disturbances while walking. They'll have a swaying, the deformities also will be noted down. And even fish oil help in reducing the cancer-related joint pains, muscle aches, neuropathy, and depressions also. And diet high in protein and omega-3 fatty acids in the days before surgery may result in improved recovery after surgery. So we have the pros as well as cons also during the dietary supplements. Majorly, they won't recommend on any dietary supplements whenever they undergo a major surgery or major chemotherapy drug they undergo into it. So we have spoken about the precision nutrition. I just want to highlight on few medicines, which precision medicine, which has been happening to it, the current approaches we are having to it. As we all know, the cancer treatment, we have the stem cell transplant, immunotherapy, chemotherapy, radiotherapy, surgery also. What is the upcoming precision medicine is like, we have targeted immunotherapies, like SCAR T cell therapy, that is chimeric antigen receptor T cell therapy. PIPAC, we have it. HIPEC, we have it, that is pressurized interperitoneal aerosol chemotherapy. Hypothermic is intraperitoneal chemotherapy. And adoptive cell therapy as becoming a promising immune therapy tool to help a patient with advanced melanoma. That is similar like, CAR therapy, we are having the adoptive cell therapy, we are having to it. And angiogenesis inhibitors, we are having to it. And even the proton therapy, we have it. The recent recommendations on radiotherapy, we have to treat the cancer cells. And even laser interstitial thermal therapy, which has been identified for treating brain tumors with metastasis. And as I said earlier, CAR T cell therapy, that is chimeric antigen receptor T cell therapy, is a type of cells where the immune therapy, the T cells is being isolated from the body, and then it is being activated with all the immune cells, and then it is being infused back to the body. So it will be fighting against the cancer cells. So the T cells and immune cells that play a several key role in the body's fight against the disease. They help the immune system respond to the disease and directly kill the abnormal cell. Unfortunately, naturally occurring T cells in the patient with cancer are not and recognizing and fighting the cancer cells. So that is the reason we have to remove the T cells from the body, from the individual, and then in the laboratory they'll be emphasizing on the T cells. They'll be boosting the T cells, and again they'll be reinfusing to the body. So extremely effective in many patients. In some cases, the treatment is eliminated all signs of cancers. So hypothermic peritoneal chemotherapy, that is HIPEC, that is usually done during a surgery in a major GI gastric cancers. They'll be doing it. Hypothermic interperitoneal chemotherapy is a cancer treatment that involving filling the abdominal cavity with a chemotherapy drug, and that have been heated to a certain degree, like 1 or 3 degrees, and pump back the abdominal cavity. What they do is they insert a tube in the abdominal cavity with heating the chemotherapy drug, and they'll be having a mild switches, and they have an outlet pipe also. And they'll be giving a nice push to the abdominal cavity up and upward and downward, so that it will be occupied. The chemotherapy drug is being occupied the abdominal cavity fully, and then the drain has been outlet. The outlet drain after a few hours, say 2 hours, the outlet through the outlet drain tube, it is being removed. So that is also one form of therapy that has been given recently. That has been followed in many of the surgeries, major GI surgery that has been happening. And angiogenesis inhibitors. This is also a cancer cell begin the angiogenesis process by sending signals to the nearby tissues by activating the growth factor that allow the tumor to form a new blood vessels, because even the new tumor cells will have their own cells, DNAs, everything will be having that. So one such molecule is called vascular endothelial growth factor. So researchers developed a drug called angiogenesis inhibitor or anti-angiogenic therapy to disrupt the growth process in order to cut down those blood vessels and all. They have formed that drug. So these drugs search out the tumors, and they will bind themselves to the VGF molecule, which will prohibit them from activating the receptors of the endothelial cells inside the blood vessels. So proton therapy, it is one similar and traditional method of radiation therapy and it has been used in different types of energy. Is being used, mainly proton is being used to treat the tumors. And as we all know, radiation is high dose of X-rays is being given to treat the tumors. So it's similarly we having a proton therapy where radiation therapy uses X-ray, a beam made of photon with a tiny particle that transmit the light, and it will give a positive, deposit an energy toward they travel to the tumor, into a tumor, and and beyond the tumors, even the nearby tissues, the major tumor cells and nearby tissues also they'll identify, and then it will be passing through it. So this result in side effects from damage to nearby healthy tissues or organs. The dose delivered to the tumor must be limited to minimize the side effect. So mainly the positively charged particle that is being given to them. So they will be having a lower dose is being given to them. The dose increases as it approaches the target area and deposits its maximum radiation directly into the tumor before stopping. So there is no exit dose. Once it's been given, it will be retained in the tumor for a longer time. So what happens is the means of tumor will be targeted more precisely without damaging the healthy new cells nearby the tumor cells. So usually within 1 millimeter, and also it allows the deliver a more powerful dose of radiation. And it is also a recent thing is the proton therapy. We have a good number. We have a good outcome also we could able to see with proton therapy. So one is the laser interstitial thermal therapy. That is the one of the thing that has been identified for treating metastatic brain tumors, which can be hard to reach the conventional surgeries, because if it is being metastasis, the tumor is being metastasis to the brain. Probably it is located in a very different areas where we couldn't able to go for surgical intervention is not possible. Probably this laser interstitial thermal therapy will help us out. So it's performed by implanting a laser catheter into the tumor and heating it to a temperature high enough to kill the tumors. The catheter is implanted using advanced computer imaging technique like MRI they'll be using to it. And the neurosurgeon will be delivering the thermal energy has been delivered with us by monitoring. The neurosurgeon will be monitoring the dosage also. So most of the patient will go home a day after the treatment. And this will take also similar like proton therapy. It will require only 2 millimeter incision of the scalp in the scalp and takes only few minutes to perform also. This laser interstitial thermal therapy can also help patients who do not respond to stereotactic radiosurgery or having a radiation necrosis also. So above all, we have seen the precision nutrition and the medicines what is being given for a cancer treatment currently. And above all, the major thing which is not being changed forever is the multimodal approach in patient care. So nutrition screening, assessment, and multimodal intervention and monitoring that we need to carry out. So nutrition screening, complete the diagnosis using a validated tool, incorporate with your planning, and then nutritional assessment with the validated tool, like either you can use SJ tool or you can use a modified SGS tool. We have PGSJ, we have to it. And multimodal intervention is start intervention as early as possible. Initiate early, recommend the nutritional strategies, and even monitor is essential once on the day 7. On day 1, we have to do the monitoring for all the patients with the help of screening and nutritional assessment. We can segregate the patient is well nourished or moderately malnourished, and then we'll start intervening the patient's diet, and then monitor the patient on day 7 on regular phases. We have to do it. If a patient is this is what it is being given, a screening of malnutrition with phenotypic and etiology criteria. If you feel that assessment criteria, there is no violation of weight loss or low body mass index or reduced muscle mass, and that is a phenotypic criteria. And etiology criteria, reduced food intake or assimilation or disease burden or inflammatory condition, either one phenotypic criteria and one etiology criteria that will be determined as malnutrition. So either it can be low body mass index or reduced food intake, that is also being considered as malnutrition. So how do you grade them is moderate or stage 1 or stage 2 is based on the severity grading is like 5 to 10% weight loss within 6 months or more than 10% of weight loss within 6 months. That is also been in the severe stage. And if it has been BMI, if it is less than 20 kg per meter square, a mild to moderate deficit of muscle mass is being noted, or if it is BMI is less than 18.5 kg per meter square, or severe deficit muscle mass is also being noted down. So any GLIM criteria we have for criteria which has been fixed for the assessing the malnutrition in the cancer patient. Either one criteria from phenotypic and etiologic criteria we can have to it. So how we go about the nutritional treatment? So is effective use of physiological method. If the gut is functioning, yes, we can go ahead with the regular diet. If you feel insufficient, probably we can go ahead with the regular diet with any oral supplement we can start. If you feel insufficient or inadequate, nutrition supplement through opening, like with the insertion of enteral of FG with the rice to feed or FJ feed or pig feed, we can go ahead. If the patient is not physiologically not normal, the nutrition is not possible through alimentary canal, we can go ahead with enteral or we can go ahead the parenteral. We can go ahead. If it is possible, we can start initiating partial parenteral also can be started. If you feel that the energy is not sufficient or energy is not supportive for the patient during the course of treatment. So as per the American Institute of Cancer Research recommendations for the cancer prevention, we have to be healthy, be a healthy weight. We recommend a patient on a healthy weight, be physically active, limit the consumption of sugar and sweetened aerated drinks, limit the alcohol consumption, don't use any supplement for cancer prevention. And after cancer diagnosis, follow your recommendations if you can. And moreover, limit your fast foods and other processed food items high in fat and starches. Limit the consumption of bread and processed meat. Eat a diet that is rich in whole grains, vegetables, fruits, and beans. So as far as concern of current thing is, though we are having the current approaches we are having to it, we have to think about it before having it before starting those particular type of diet for a cancer patient. So multidisciplinary effort is essential in providing the patients with good nutritional support, and nutrition assessment and screening is essential in patient undergoing cancer treatment, and early nutritional intervention is essential in the better outcome, and frequent monitoring help to modify the diet plan. Thank you. If possible, I can go ahead with the video. Is it possible? A small video, I just want to run through it. Is it possible?
Thank you, Rajeshwari. It was an excellent talk. Enjoyed the importance given to calorie deprivation and importance of a ketogenic diet, and the very fact that supplements have to be handled very carefully in these patients, because some of these supplements themselves can increase the risk of recurrence and produce toxicity. I enjoyed listening to you, Rajeshwari. Thank you so much.
Thank you very much, ma'am. Can you unmute yourself, ma'am?
Yeah.
Yeah, ma'am. It was really wonderful, ma'am. Your session was very informative. Thank you
Thank
very
you.
much, ma'am, for taking time to be with us. So we have a small case study, ma'am. If you can just
No issue.
listen to us, it will be great, ma'am.
Sure.
Good afternoon all. Good afternoon, ma'am. So today I'll be presenting a case study on cancer patients. So the demographic data of the patient. So the name of the patient, Mrs. Dhanvanti J. Shah, age 74 years, gender female, community Jain, economic status upper middle class. So we all know cancer is a disease which involves abnormal cell growth, and it has the potential to invade or spread to other parts of the body. So it also causes changes in the bowel movements, and also it shows us several signs and symptoms in the body which has not occurred in the past, which sometimes goes unnoticed. The use of these synthetic, natural, and biological agents to minimize the occurrence of cancer in healthy individuals is defined as chemo prevention, cancer chemo prevention, in which we'll be using the natural biochemical or biological agent. Here, the natural agents are through food and phytochemicals, and biological agents through medicines and through the therapies which is given to the for the management of the cancer. Chemo prevention is the use of natural, synthetic, or biological agent to prevent, suppress, or to reverse the initial phase of carcinogenesis, or to prevent the invading potential of the pre-malignant cells. Clinically, chemo prevention has been categorized into primary, secondary, and tertiary. Primary and secondary chemo prevention is suitable for the general population for the prevention of the cancer, and also the population at high risk of developing cancer in the lifetime. Secondary chemo prevention is intended for the patient with pre-malignant lesion, which may progress to the invasion cancer. So for the examples of primary chemo preventive agents, dietary phytochemicals and non-steroidal anti-inflammatory drugs such as aspirin. So we can use dietary phytochemicals in the prevention of cancer, and also after for the treatment of cancer, and also the management of the cancer. For example, capsaicin, catechins, lycopene, cucurbitacin B, and isoflavones, polyphenols, etc. Capsaicin, it is present in the bell peppers, which helps in inducing apoptosis process, and catechins is present in green tea and also so many vegetables. Lycopene is present in all the red colored pigmented fruits and vegetables. And then isoflavones, all these are present abundant in the fruits and vegetables. So the anthropometric data, height 152 centimeter, weight 70.9 kg, BMI 30.6 kg per meter square, which shows she is obese, grade 1. IBW 48 to 62 kg, and SGA is 10. Showing the biochemical data, it shows that the patient is the patient's hemoglobin is low and it's anemic, and the packed cell volume is low. That's 28%, which is anemic, and she has a little bit elevated level of urea, which is uremia, and her creatinine level is also elevated, and she is also a CKD patient, and all other things are normal. The medication she was currently given was tablet Conquer, which is used in the treatment of hypertension, angina, etc. Tablet Razel, which is low lipid lowering drug, and also reduces the risk of heart disease. She was also given injection human albumin to treat hypovolemia because her blood parameters and the hemoglobin level was so low. Tablet mini press, which helps with the high blood pressure and reducing the risk of heart attack and stroke. Tablet nodosis used in the treatment of heartburn and indigestion. So the clinical data of the patient diagnosis, she was diagnosed with cancer in stomach and anemia, hypertension, type 2 diabetic mellitus, hypothyroidism, chronic kidney disease, and iron deficiency anemia. So the past procedure she underwent was a CRAO in left eye, and the present surgical procedure for the treatment of cancer, she underwent proximal gastrectomy. For the dietary assessment, we have taken food history. She is vegetarian, and for the religious restrictions, onion, garlic, and roots and tubers. Route of nutrition is oral, and we have taken 24-hour dietary recall. So her home dietary recall. Early morning, she consumes tea, and for breakfast, she consumes khakra. For mid-morning, Horlicks milk. Lunch, roti, 2 pieces. Bhindi sabzi, 100 grams. Green gram dal, 50 grams. Rice, 100 grams. Buttermilk, 250 ml. For tea time, she consumes tea with some snacks and chips. Tea, 120 ml, and fried snacks, 50 grams. 6 p.m. she consumes Goa, which is 100 grams, and dinner dhokla, 4 pieces. So the oil I have given 20 ml. The total calories was 1576 calories, and carbohydrates 221.6 grams, and for protein it is 57 grams, and fat 54.3 grams. Food frequency, she consumes cereals daily and millets rarely. Pulses every day, other vegetables every day, roots and tubers she never consumes. Green leafy vegetables weekly, nuts weekly, fish, egg, chicken, mutton, meat, and seafoods she never consumes. Sugar she consumes every day. Fats and oils every day, and other supplements she does not consume any other supplements. So 24-hour dietary recall in hospital. Early morning, she was on the liquid diet on the first day. Early morning, she consumed the milk 120 ml. Breakfast, it's sweet lime juice, and then she was given Kabi Pro, vegetable clear soup, and then apple juice, then milk. So the total calories she met on that day was 463.8 kilocalories, and protein 14.4 grams, carbohydrate 70.4 grams, and fat 8.76 grams. So the percentage she was able to meet with the daily requirement was 23.2% for protein, and 25.2% for carbohydrates, and 16.9% for fat. On the second day, she was able to tolerate solid diet. She consumed the tea in the early morning, 120 ml, idli 2 pieces, sambar 3/4 cup, dal chutney 1 cup. She was given Kabi Pro 100 ml, rice 1, chapati 1, rice half cup, bindi poriyal 1 katori, more palambu 3/4 cup, curd 100 ml. And for the evening time, she was given tea 100 ml, sundal 3 grams. And for dinner, she consumed idiyappam 3 pieces, chana kurma 3/4 cup. For bedtime, she consumed milk, which is 100 ml. And and for oil, it's given 25 ml. And the total calorie was 1481.8 calories, and protein 54 grams, carbohydrates 208.5 grams, and fat 41.3 grams. The percentage she was able to meet was 87% with the of the daily requirement of calories, and 74.5% of protein and 80% fat. On day 4, day 3, she was on NPO for the gastrectomy procedure. She was not able to eat anything, and the next day she was started with liquid diet. Clear vegetable soup, strained fruit, clear vegetable soup 100 ml, strained fruit juice 100 ml, strained carrot juice 100 ml, sweet lime juice 200 ml, clear vegetable soup 200 ml, strained pomegranate juice 200 ml, and strained watermelon juice 200 ml. So the total calorie which was met was 405 kilocalories, 2.5 grams of protein, 99.5 grams carbohydrate, and 0.3 gram fat, which only met 3.3% of the daily requirement of protein, and 35.6% of carbohydrate, and 0.5% of fat. On the last day of discharge, she consumed early morning coffee. For breakfast, biscuits, 2 pieces, and Horlicks milk, 100 ml, kanji rice, she was given 200 ml, pomegranate juice, 200 ml, and for dinner, idli sambar, idli 1.5, and sambar 3/4 cup. For bedtime, she consumed tea, which is 60 ml. So the calorie was 741 kilocalories, and 23.9 gram protein, and 108.6 gram carbohydrate, 22.9 gram fat. The percentage which was met 38.5 grams for carbohydrate, and 38.9 gram for protein, and 44.3 grams for fat. So this is a recommended nutritional requirement for the patient. Energy, it is 1860 kilocalories. I have given 30 kilocalories per kg IBW. And for protein, 1 gram per kg IBW, which is 62 grams. And for carbohydrate, 60% of the total calorie, which is 279 grams. And for fat, 25% of the total calorie, which is 51.6 grams. And so as she is a CKD patient, I have given 3 grams of salt and a fluid restriction of 2.2 liters. This is the deficient calculation. On the first, the energy requirement of the patient is 1860 kilocalories, and the protein 62 grams. On the first day, she was able to meet 463.8 kilocalories, and second day, 1481.8 kilocalories, and fourth day, 405 kilocalories, and fifth day, 741 kilocalories. The protein intake on the first day was 14.4 grams, 54 grams on second day, and on fourth day it's 2 grams, and fifth day it's 23 grams. The percentage of energy deficient on the first day was 75%, and for protein deficient it is 77%. And on second day, the energy deficient was 67%, and for protein deficient percentage it is 13%. And on fourth day it is 78% deficient, and protein it's 95% deficient. And on fifth day it's 60% deficient, and for protein it is 61% deficient. PES statement problem, she has anemia. She was not able to consume anything because she had chronic constipation for a week. And she also does not include any iron-rich things in her diet, as it is evidenced by the food frequency recall. And signs and symptoms, She has pale skin, fatigue, and weakness. Sample menu. Early morning, I have given soaked almond plus poppy seed milk, 120 ml, and whole wheat bread, one. Uh, Poppy seeds helps in relieving constipation, and it is also reduces the inflammation in the body, and it is a powerful antioxidant. For breakfast, I've given idli and rich gourd peel chutney as it is low in potassium. For mid morning, fruit salad, pure apple, which is also less in potassium, and I have given Nephro HP 2 scoops plus 50 ml water. For lunch, I have given Bisibalabad, 1 cup, chapati 1, fenugreek leaf poriyal 1 katori, curd 50 ml, as it is a probiotic. Evening, turmeric milk and dhokla. Turmeric milk 120 ml, dhokla 2 pieces. Dinner, I have given green gram adai, tomato chutney, and cucumber. Green gram adai 2 pieces, tomato chutney 50 grams, and cucumber 50 grams. Nephro HP on the bedtime 120 ml. So, this is a sample menu exchange. I have given cereal 7 exchanges, pulses 4, fruit 1, almond 10 grams, poppy seeds 10 grams, mango green chow chow, all it is being put in the Bisibalabad. So, I have given 20 grams, and Nephro HP 4 scoops, snake god fenugreek, snake god 20 grams, fenugreek leaf 100 grams, milk 2.5 exchange, fats and oil 5 exchange, salt 3 grams. So this adds up to 1,820 kilocalories, and protein 70 grams, carbohydrate 245.3 grams, fat 56 grams, sodium 1,374.6 mg, which is within the daily requirement limit, and potassium 1,704.9 mg, and phosphorus 270.6 mg. Summary: Mrs. Dhanvanti J. Shah, 74-year-old female, was admitted with the diagnosis of moderately differentiated adenocarcinoma of stomach with anemia and with the known case of CKD, hypothyroidism, obese, type 2 DM, and the patient has underwent gastrectomy as a treatment for stomach cancer. Hence, high calorie, high protein, carbohydrate greater than 55% is recommended with iron-rich diet to increase her hemoglobin level. Thank you.
Can I unmute yourself? If you have any observations, you can just ask.
Yeah, sure. Oh, yeah, it was nice presentation. I just have three queries I had. You have assessed the patient as obese, right? So why you recommended 30 kilocal per kg body weight for the patient?
Ma'am, she has underwent a surgical procedure, so she needs more calories and protein. But protein we cannot give much because she is also a CKD patient.
CKD.
So I have given 30 kilocalories.
Okay. So, but that you can step up with like 20 kilocal, 25 and 30, we can go ahead, but not initially. We can start with 30. It's too high for post-operatively. That is what I felt that. That's the reason I asked. And what is the reason day 1, day 2 and day 4? The nutrition intake wise, it is very minimal. Is it any complications she come across intake?
Yes, ma'am. She had constipation problem for a week. So she was able to eat anything. And that's the reason. She had constipation and this bloating issues. So she was not able to eat anything, and the patient was also stressed.
Okay. And for CKD, is it fine to go ahead with green supplementation when you're having a meal plan or something like that? You recommend greens for a CKD? Yeah.
I have given fenugreek leaves, ma'am. It is less in potassium when compared to other green leafy vegetables. So I have given,
I monitored the potassium levels, everything during the phase of hospital stay.
yeah,
You have noted down.
yes, ma'am.
Your potassium and sodium and potassium level, is it being monitored during the hospital stay?
No, ma'am.
You have not done it. Okay, okay. Because these are three things I just want to have it. Otherwise, the presentation is very good. And why, one more thing is why, being a partial gastrectomy, why I have chosen Nephro HP or Carbipro in spite of any other semi-elemental supplements?
Why I have chosen Nephro HP?
Yeah, why you have chosen Nephro HP or Carbipro rather going for any semi-elemental formulas?
Because she's a CKD patient, ma'am. That's why Nephro HP is comparatively
Chosen.
low potassium and sodium. So
Okay. Because certain semi-elemental formulas also, because are already partially gastrectomy, the part of the stomach is being removed. So only 3/4 or half of the stomach is being retained. So which is easily digestible and which is low in potassium can be recommended in such cases. It's not that we can overload on protein or something like that. But even normal semi-elemental formula, which is easily digestible and which has been easily recommended for a patient and that particular phase. You have partial gastrectomy means only 3/4 of the your stomach is being retained or half of the stomach is being retained. So in that cases, that should be easily digestible and that should be give some nutritious also. So it's fine. So these three things only I've observed it. So I wanted to ask. Fine. Thank you.
Thank you, ma'am, for
Thank you so
for being
much.
with us and sharing being the speaker of the day. Thank you very much, ma'am.
Thank you so much. Thank you. Ji.
Bye.
Bye bye.
Bye. Ma'am. So now it's recorded. So number recorded. Recorded.